Thank you so much. Are you able to hear me okay? All right, good. So I actually removed two-thirds of the slides that I had because we've got such a brilliant group of people that are going to be on the panel. I'm going to shorten the, I'm going to go against what I was told to do. I'm going to shorten the initial slides and ask the panel to come up here very, very quickly. So, okay, So all of us on the panel today have a very, very different role and a very, very different perspective on this particular issue, and it's a massive issue. So we're going to select several things to really focus on. But one of the things that's clear is that as we go from kind of bench to bedside, there's a tremendous inequity of what's happening right now. And the ability to go from understanding what we can do to add years to the life and life to the years of the people we serve and what's actually happening almost are divorced completely. So when we think about the data science and what's happening right now, this rapid acceleration in our understanding of what to do and how we can do things and how we can change lives and become much more efficient and effective. And then the second question, of course, becomes how do we actually put that on the street? How do we actually affect people's lives and change the care that they're receiving? Right now in the United States of America, we know that the care is 3 times more expensive than it is in many other parts of the world. We know that there are a lot of very inappropriate things being done very frequently. And so if you put unstructured AI on healthcare, all the healthcare data in the United States, what you do is recommend a lot of inappropriate, unnecessary things to a lot of people. So obviously it's got to be much smarter than that. And ultimately, there's got to be a human filter on how that data, knowledge, and information is translated into action by the average person. So as we get better and better in understanding this, the next question becomes, how do you swim upstream? How do you get to disease earlier? And instead of doing what we do in the United States today, reactive care, how do we get to preventive care? And of course, one of the beliefs that I have very much is that primary care and preventive care are investments. All the rest of the money spent in healthcare are costs. So how do we swim upstream? And finally, that's going to change the population health, and or we're dealing with multiple different populations, as Asif was just talking about. So how do we distribute these findings in a way that help tremendously? So my company is Converging Health. We have about 350,000 people that we do advanced analytics on. We've now incorporated machine learning or structured AI and large language models into it. And what we find when we look at the average population, we have we work with ACOs, Medicaid populations, and Medicare, and we work with corporations in America. And what we find is that when we look at the population, there's about half of them that are low risk and low cost. And these are people that often receive very inappropriate, very expensive excess care, but they're also folks that need to be engaged in order to keep them from becoming high risk. They will have things happen like they'll become pregnant, they'll need an appendectomy, a cholecystectomy, things like that, or they may have a blood clot, they fracture their leg trying to ski backwards, and then they'll come right back down. But this is the group, this high-risk, low-cost group, that when you look at AI and machine learning, amazing things come out of this. And the question for my company is how do you intervene with these successful to keep them from becoming those that spend 80% of healthcare? Because by the time they get there, it's too late. I say it's too late. They're going to regress to the mean in terms of cost. They're going to heal to the degree that they can, but often they will never go back to where they could have been if we had intervened appropriately. So one of the interesting things in our findings, and this is the last thing I'm going to say before I ask these amazing people to join me, is our formula looks at 3 things. First of all, what's the absolute risk? What are the diseases a person has? How many medicines are they on? What are they? What's their social determinants of health? What are the corporate determinants of health, which is asking the question, do they have insurance? And if they do have insurance, does it encourage engagement in their care or discourage engagement in their care? And we call that absolute risk. The second thing we look at is how is the care that they're receiving being delivered, and is it capable or not? And the third thing is how are they participating in their care? And the most predictive of the 3 in determining who's going to have an event, not just cardiac, but an event of any kind, is how they're participating in their care. It's amazing when you look at the risk from an absolute standpoint and the care that people are receiving, which is usually mediocre, it's medium care. It's not really pathway-driven effective care always. or the majority of the time. It's their engagement and health literacy. And this model that I show you here is actually the one that the federal government has adopted in the health literacy work that they're doing for Medicaid, Medicare, and CMS, and it was developed by Pat Dunn. And so this is the Dunn model of health literacy. And what we have found is assessing the knowledge, testing the numeracy to see if they understand what the numbers even mean, helping them navigate the system and be able to communicate their needs, and ultimately to make better decisions is the thing that will determine and will decrease future events. So that said, I'm going to stop here and ask Michael, Asif, Francois, and Malik to come join me. We have 4 very different perspectives on this, and it's very excited to have them here. We should all have, could I get the microphones brought up here, please? Testing, testing. Here we go.
Thank you.
Here, let me do it in order. 1,
Oh, okay.
2.
Thank you, Bob. Thanks.
So as we look at this AI and how it's revolutionizing healthcare, we're just going to go down the line and ask each of you to introduce yourselves and what you see that is the most important thing and what you think that will make the greatest progress on quickly, and for those watching, how they can participate, what you see is the need. And we'll go quickly, and just each of you take 5 or 6 minutes, and then we'll come back with questions that come up.
Happy to start. Thank you for having me. My name is Malik Majmudar. I'm a cardiologist, obviously, like most people here. I'm a co-founder and CMO of a company called Bioformis. The company is really just focused on shifting site of care from brick and mortar hospitals to the home environment. So we deliver care through technology as well as a provider group. In terms of AI, the 3 areas where we leverage AI specifically in our model of care, first is physiological monitoring. How do we monitor patients outside the hospital and use AI to determine the risk of clinical decompensation that we talked about? Second is how do you think about AI in terms of early diagnosis? How do you detect complications of disease or complications of treatment? And the last piece is really around medication optimization. We talked about guideline-based medical therapy. How do you leverage software and AI to really drive appropriate medications, initiating and titrating them at the point of care? Briefly, in terms of, areas of opportunity, this could be an hour-long conversation, so I'll be very brief. I do think the biggest gap I see currently is that there's a lot of work in the research and discovery phase around AI, but very little validation or adoption of the technology in the clinical setting. So the value of death for most companies or more academics who work on this stuff is really around adoption and scale. And we can talk in the panel today, hopefully, about the different ways to approach that.
Malik, great points. I'm Asif Ali. I'm also a cardiologist from Houston, Texas. I'm a clinical assistant professor at UT McGovern and U of H Medical School. I run as the director of Cena Research Institute. We're all about clinical research inclusivity. We just had a talk about it a minute ago. So talking about AI, in January I put out I'm also on the Health Tech Advisory Group as the group here, and we talk about this all the time, and I'm on the AI Advisory Board as well for the AHA. So when I had conversations in the LinkedIn world about how does AI help the churn of the patient journey through the engagement in this big healthcare ecosystem, I had a lot of companies call me and say, we're an end-to-end solution. Started becoming my pet peeve because I'm not sure if there's a real end-to-end solution. I think we're too early to have an end-to-end solution, my opinion. So I went through really methodically thinking about that patient journey. So I think we need to have some guidelines and nomenclature around how we talk about that patient journey in AI. So pre-engagement, engagement, post-engagement. Pre-engagement, we can actually send out adaptive algorithms. In fact, Scott and I just did AI avatars of ourselves yesterday. So it's literally a digital twin. So we can actually create digital twins of a vetted source that could actually talk about health equity, talk to the patients as that vetted source, almost as an AI physical chatbot that you could see on your phone that could start actually asking questions before you even see the doctor. So that's the pre-engagement. Engagement, we're very familiar. Engagement is ambient listening. It's the history taking and describing when I'm seeing the patient. But I'm still having to take the history. So the pre-engagement, I could do that using AI, adaptive algorithms, not questionnaires, adaptive algorithms, just like I would ask, patient would tell me their chief complaint. Based on their answers, I would adapt my questions. We could do that in chatbots. We could do that on a phone call. And very soon, a digital twin of the doctor before the patient even sees the doctor. Then you have the engagement, we have our time there. But imagine if we had the engagement part and you have an ICD-10 code. So one of the things that we're working on now through a company here actually called Tabia Health AI is after the ICD-10 code, we've actually integrated the clinical care pathways that Pat Dunn created, and the patient actually leaves with education awareness of their disease process through this clinical care pathway that would be SMS text and videos sent to the patient about their condition. So imagine someone just found out they have heart failure. It's almost like saying you have cancer, and the patient has to go home and talk to their loved ones about what heart failure is. Well, we know that they're only going to remember 30, 40% of what we all told them. So how do we do better patient engagement? How can AI help through that? And then the post-engagement as the last part is adherence and behavioral changes. Adherence is so important for whatever we do. If you don't adhere, if you don't have those behavioral changes, and that stemmed through education and awareness and health equity of your disease. And we have to wrap all of that in with ethics and frameworks that we could also have an hour talk on.
So I want to say thanks to Pat Dunn for the opportunity to be presenting here, Patrick Wade and the CHTI team for this wonderful opportunity to engage with each other. My name is Francoise Marvel. I'm a cardiologist at Johns Hopkins. I am also the co-director of the Digital Health Lab at Johns Hopkins. I'm a preventive cardiologist and also am a co-founder of Corey Health, which is a digital health patient engagement platform. I think the promise of AI is really coming from a preventive cardiology standpoint in the prediction to intercept, detect, and manage a cardiovascular event or health event before it causes a catastrophic clinical decline. I'll briefly give you an example. We take care of many patients who at very young ages, unfortunately, 42-year-old out on the treadmill with a family history of coronary artery disease and MI in the family that occurred early, and has, unfortunately, although no evidence had been picked up on prior exams and evaluations, even though maybe that EHR suggests the lipid levels were a little bit high, the high cholesterol was really, could have been managed a little bit better if that person had had a coronary calcium score that was maybe overlaid with an AI algorithm that could have detected, my goodness, there's plaque that's in the LAD and it's pretty significant for this young age. Let's go ahead and signal an opportunity for treatment and management earlier. I think that clinical example is where AI already has the potential through what we're doing with CT scanning, non-gated imaging, imaging overlaid AI to detect disease early, and then to guide through clinical decision support tools the ways that our clinicians can deliver guideline-based cardiovascular preventive care optimally and help to ultimately save lives and prevent events that could lead to better lives for our patients and our community. So ultimately, there are many uses of AI that are very impressive, from research to making our jobs easier as clinicians to making our lives happier as patients and community members. But I think where I'd love to see this make a tangible difference is in screening and detecting and allowing us the opportunity to intervene earlier to help prevent cardiovascular disease.
Yeah, I'll add my thanks to Pat and the CHTI team for the opportunity today. I'm also, as the rest of us, part of the Health Tech Advisory Group. I'm Mike McConnell. I'm a cardiologist, also primarily a preventive cardiologist based at Stanford, but I've worked with a number of large and small health tech companies over the last 10 years. And I think the panel has already highlighted lots of opportunities for AI. I think I'll sort of connect the two companies that I work closely with, one called Toku and the other Porter Health, I think highlight what I think are major opportunities for AI. They're both also part of the CHTI's Innovators Network, so appreciate the opportunity for working with the AHA to help with this. But I think as Francois has highlighted and others, that to me I see the opportunities sort of at the front end. How do we identify many more people who are at risk, who through our sort of the current inertia in our healthcare system don't get picked up early enough? And then at the other end, we have all this great data that's often buried in EHRs and guidelines that get updated and get more complicated. That is very hard for especially primary care docs to keep track of. So how do we help on that, implementing these life-saving guidelines appropriately? So Toku actually is trying to turn a research study that we did at Google showing AI of your retinal images, which has lots of information about your blood vessels, where heart disease starts, that AI can predict your cardiovascular risk, similar to the cardiovascular risk scores that we use in clinic. But trying to get that into a product, I think so. Toku is a company I work with that, you know, we have FDA breakthrough device designation for that, starting our pivotal trial. So really, how do we bring that idea that we can hopefully identify many more people who have blood vessel evidence of early disease, so we can bring them in so they can see Francois or myself and get on appropriate preventive therapy. At the other end, you know, we have these guidelines that are showing that early detection, early treatment can largely be curative of heart attacks and strokes if we really follow the guidelines and catch people early enough. And there's a lot of data in your EHR about your risk factors, about already sort of subclinical evidence of disease. So with Porter Health, we're looking at how do we identify that data, how do we link that with the newer Prevent Score, CKM staging system that's been developed, our Life's Essential H score. Many of those things would take you most of your clinic visit just trying to calculate and find all the data. So the idea is you could start your clinic visit with all that essential information linked to the guidelines, and then with, you know, here's what the data says about your stage, your risk scores, and linked to appropriate guidelines for you specifically, so you can start your visit really with the idea of, okay, where do we go from here to help? So I think both ends of the spectrum can really benefit from AI and the tools that many here and, you know, at the sessions are working on.
So as we think about this, and by the way, I would ask you to hold your
Oh,
that a little closer. It's difficult to hear. So as we think about this, when you look at the high-risk, low-cost people, they're costing about $1,200 to $1,500 per person per year. I'm trying to make this practical, okay? I'm pulling this back to this is America today. And then you see that they have an event. And what we have done is we've gone back and looked at the events that have them become high cost. 70% of the time, if they had received preventive, proactive care, they would not have had the event. Francois, it's exactly what you said. So the question becomes, how do we go from this potential to putting it on the ground? One other thing I just wanted to refer back to Steve for a moment with what he said. If you took all the data for the people in the right lower quadrant and you ran it against the algorithms that the company, what's the name of that company?
First is during the pre-engagement and the post-engagement Tabia.
Yeah.
Tabia Health.
So what you'd find is that the adherence to national guidelines is probably less than 20% at best. And you could also look at all the doctors in the United States and rank them based upon their following the guidelines. And you could also identify in the data, which is relatively easy, the fraud, waste, and abuse that's occurring. So if you just unleashed structured AI on data, we would be able to root out those that are not practicing properly, identify those that are practicing properly, and then be able to prevent events up to 70% of the time. So how do we get there, and how do we move the dime, or get down that road as quickly as possible? What do you see as ways to do that? Yeah, Mike, you go first. We'll reverse the order this time.
I'll jump in because I think that's sort of the last topic that I was maybe didn't harp enough on. Is honestly, it's become really, really challenging to find all the data, because I think, right, you're saying that high-risk, low-cost group, they're tools, but it's often buried in the EHR. Most people with CKD don't know they have CKD. Their doctor doesn't know they have CKD. Many people with hypertension are not given that diagnosis. There are people with coronary calcification on a CT scan that is even in the report that nobody notices or acts on. So the data is actually in there to move people from what they're told they're low risk, low cost. They're truly high risk and could be high cost. And so using AI to sift through that data, identify the high risk folks, and the parallel to that is keeping track of all the updates and guidelines as they get more complicated, right, preventive cardiology, we have the luxury, that's our focus, but for primary care, where most of frontline care is happening, they're trying to do everything. And so unless you make that easy and fast, I can't blame them for not following guidelines when we don't give them the tools to make it easy to do.
Yeah, go ahead. Just to add to that, I was going to say, Mike, the nuance here is that part of the opportunity for AI, what Mike's mentioning, is really around the early prediction or better risk stratification. But for those sort of situations, you already know the management, what comes next. The second part of AI is really around clinical decision making at the point of care. If you already know the risk, how do I actually, you can't memorize hundreds of pages of guidelines. How do you have tools at the point of care to go implement those in a timely manner? The third part is there are going to be opportunities where AI will predict risk where we don't know how to manage just yet because it's novel science. And there's where we need the validation to then go actually prospectively validate what is the next management step. But I think vast majority of the opportunity is in the first two, which we already know what to do. We're just not doing it, and we have the risk scores.
I'd just like to harp on, Mike and Malik brought up great points here. I'd like to challenge the audience, I think for the clinicians out there, as a thought experiment to explore. Our EHRs are very powerful tools, and to use an example from Hopkins, we took exactly what we're describing here in terms of we use lipid panels to try to figure out where are and ICD codes for STEMI and STEMI, evidence of ASCVD, and then looked at LDL-C levels that were elevated and just mapped. Well, if this person's secondary prevention, it's not rocket science. They've already be below 70 or 55 ideally. So if they're not, can we put them in a folder and put that folder in someone that we review and see if we're either unveiling an inability to adhere to statin therapy, maybe they need non-statin therapy, or maybe they need to be in the hands of a cardiologist or a lipid specialist. And then we also created another higher level of LDL-C to try to figure out, are these patients maybe undetected FH, like the earlier patient I mentioned on the treadmill who had CAC at a young age and all this had been missed. So the data's there, but doing something like that in your EHR, I thought it was going to take forever, but it really didn't take that long to put something like that together, and it will surprise you when you start to see, gosh, I thought I'd maybe pull like 10 or 12 patients, and it's more like 200 plus patients in the first day that you run the scan. So in the audience, if you're interested in clinically applicable AI that you could go home after this conference and start doing, I'm no AI, I'm grateful to be on this panel, but I am not an AI scientist, but I am a clinician that knows the data's there and that these kinds of algorithms and applying this kind of logic can get basic questions answered where we're missing clinical opportunities to do better treatment and keep those high-risk individuals treated earlier and avoid those high-cost readmissions for revasc and complications.
Yep, just quick footnote, if the federal government would come out and say anybody who takes $1 of federal funding for anything all of their data goes into a national de-identified database that every data scientist can get access to and run the algorithms against and do it. That might be the thing that would turbocharge so much of what we're doing. Asif, what are your thoughts? Not about that. Go back to the important.
We're going back to the EMR.
Okay.
And billing on EMR, last time I saw, is based on ICD-10 codes, right? So you have to make a diagnosis, and that's your ICD-10 code. So the question is, in that high risk, low cost, once you have a diagnosis, it's all about adherence and behavioral change. Because we know one of the biggest predictors of your outcomes is your zip code. And that high risk group typically are in zip codes where you have food deserts and things of that nature. So assuming that we were able to get those individuals into the healthcare system and then make a diagnosis, then the question is, how do we, exactly like you have on the slide here, right? Behavioral approach happens with education and awareness, and get with the guidelines. And look, all of this AI stuff has to be fundamentally based on a strata or a foundation, and the foundation is here. We're at the 100th year of the American Heart Association. So when we're talking about even AI, closed neural networks need to be based on the foundation of standard of care, which is the American Heart Guidelines. And get with the guidelines is just that. And I think the discussion here is an HCP, which is now defined as, it's not an MD, it's not a DO, it can be many flavors. How do we get all of the stakeholders to get with the guidelines, right? And I think that's where having that ICD-10 code and moving from there. And one of the areas that we're trying to solve with Tabia, and Tabia, by the way, in Swahili means behavior. So we're trying to change behaviors. And behaviors comes with education and awareness. And what we're doing right now is embedding actually the clinical care pathways after that ICD-10 occurs and the patient gets information to them. Now, I think there's a whole health equity in how do you get that information to them. Is it SMS? Is it email? Is it, how do you disseminate that at a level of understanding for that individual? And I think that's very important too, not just a package that we hand out, but something that's actionable and requires a two-way process.
So one of the very interesting things that Dr. Dunn and I spend our life doing all day is we know what to do, but we're not doing what we know. And exactly that interface that you're talking about, Asif, what is the initial interface and what does that look like? And just to cut to the chase, what we've learned is that knowing doesn't matter until you know the why of that person. So it's a huge mistake, and I think I, as a doctor my entire career, which is now 4 decades, have made is I think if I will teach them and they understand it, that they'll act on it. But actually, until I know what their intrinsic motivation is and their feeling of empowerment in the world, it's just a bunch of hot air. So this is where AI and being able to speak to that person in the language that they understand and building that pre-engagement relationship, which actually I am not convinced AI by itself can do that. What I'm convinced of is that large language models can go in and using AI can identify key things around that person and hand it to a human being, and that human being can develop a trusting relationship, and then the AI can inform what needs to come next. So they're always one step ahead. And we actually use medical assistants. I know that might be heresy, but medical assistants and social workers to establish the relationship and to guide the person to the right healthcare resource or clinician.
But Scott, I also want to point out in that pre-engagement, pre-assessment, we have to give a voice to the patient. We don't do that often. When they come in for the history with us, look at the time that we get to spend on really complex patients. It's not fair for the clinician and it's not fair for the patient. So giving time for that patient, that pre-engagement space to give a voice and empower the patient, we need to focus on the patient empowerment. And that starts before the patient even sees us.
Right. And knowing them as a human being is what I hear you saying. And so so if you took the process of care, the pathway of care, and you got rid of the garbage that we as clinicians have to do around the documenting, which you talked about, the Sensit, we're now recording all of the conversations that gets combined with the large language summary that was put there, and then the care plan at the back end is also generated by AI and handed back to the clinician. So it's yep, wait, that one we need to modify, yep, and that goes into the Epic what's it called? There's an area where it has that everybody sees that has the it's not called the playground, but there's a name for it that goes there. So now the entire healthcare team knows what's happening. And silly things, almost trivial things like that, save so much time, energy, and effort for the clinician, so they can actually build the trusting relationship. So what about you with you talked about hospice, and one of the things that I find most sad in America today is how many people we put through multiple rounds of chemotherapy when if they had been given the choice, they would never have gone through it. They would have chosen to be with their family and live at home and die at home, but we don't engage them early. So do you see AI and early engagement and maybe kind of this chatbot, or not the chatbot, but the virtual digital twin that can be armed, going out and having some of these conversations to prepare people for some of this pathway of care work?
Yeah, I think the opportunity on that one is twofold, right? Part of it is really back to the point earlier around risk stratification. Can you really understand, in that example, specifically oncology, is the longevity and not just lifespan, but health span and the quality of life? So can you have a better model with all the data that we talked about is available in EHRs and social determinants of health? Can you have a better risk prediction model? But the second part is really personalization, right? This is where AI does a better job than we as clinicians do. There's been studies at Harvard looking at this idea of empathy, and in a clinical trial that was published in JAMA, they showed that responses by automated large language models were more empathetic than actually clinicians educating and coaching in clinic, which is incredible. And then to your point earlier, I think conversational AI is actually getting a lot better to a point where patients probably can't distinguish between those phone calls made through automated systems, and that allows us to scale, right? So you have better empathy, and you have conversational agents. It feels like a real conversation that really allows us to take the right models of care and really scale them in a way where there are physician shortages right now. So to Asa's point, you have this large team-based care model, but how do you take the expertise of a physician and scale it? You use AI for those things.
We need those empathetic models for customer support too. We don't really get those, but I agree that, I think there's a big divide right now when we talk about digital avatars and you're talking about empathy. I mean, we've seen those models were phone calls and more kind of verbal chatbots. I think we haven't figured out quite yet about the digital twin, the avatars. I think this is a very fresh area. I really imagine that you left a doctor's office with a diagnosis of heart failure, and all you're retaining is 30% of that information in your brain because you just got this devastating news. What if you had Francois on her digital twin when you go home saying, I understand that we just gave you a diagnosis of heart failure. Let's spend some time to talk about it. Let me tell you what you should be eating, how much exercise.
Or what would you like to know?
Oh, what would you like to know? And it could be interactive, right?
What are your questions? And
What do
how do I go to your understanding? What is the heart?
So we don't have that yet, data yet, but we're working on it. And that's what this group and HTAG, and that's, I think, the exciting next frontier. What Malik was saying, that the digital twin may be more empathetic. You may have had a tough night last night, and your voice coming across may not be as empathetic, but your digital twin got plenty of sleep, so they can take it
My
from
wife
there.
is going to want to marry my digital twin. I may be traded in. I don't know. Well, Higgy is one of the other innovators, programs here, and I went yesterday and looked at their demonstration, and basically they take all the data that they get from a non-local visit, give it to a clinician who comes up with the problem that they identify, and then it starts running algorithms. I've already gotten like 26 texts, and I will tell you, Francois popped up on my phone and said, Scott, you haven't exercised today. Can we talk about this a little bit? Why isn't that occurring? Take a picture of your next meal also, Scott.
Did that change your behavior?
Oh my God, I'd be getting in line. That's right. I think.
Get with the guidelines,
I have a
Scott.
very
Get
serious
with the
avatar.
guidelines.
Yeah, that's right.
I think this discussion really, it makes us thinking in the audience as well, what is it going to be like when we have extenders of ourselves that are driven by AI? And when are they going to start competing with us? And it's not competing, it's collaborating. It's enhancing our ability to deliver care and not miss things. We have to understand, as humans, we're fallible. Someone's gonna glaze by that CAC score and a young person say, oh, just hit the gym. It's like, wait a second, you were in the 99th percentile and you have a strong family history. That's a miss. Guess what? AI wouldn't have missed that. Right. And that's what we're faced with, and we need to build these tools in they're not even safety nets, they're enhancers. And then you turn yourself into that version, and if I'm on Scott's phone, it's going to get real. I have a feeling my avatar is not going to back down from
I know. I'm already looking forward to that. Well, we're out of time, but I'd love to, first of all, I want to really thank you all tremendously for being who you are in the world, because you're leaders, you're out there, you're educating, sharing, and you're setting the pace for the future. And this is what we need right now. It's very, very important. So I want to thank you all tremendously, and thank you all for coming and joining us today. I hope this is of value. And we will now get out of the way because it's time for the community panel to come on up. And then, but we will be around, and after the community panel, if you'd like to come talk with these esteemed folks, we'll be at that table, and we'd love to have you come join us. So we'll leave now, and on we go with the community care, transforming public health.
Thanks.
Do we want to do a?
Oh yeah.
Do we want to do a quick picture? Do you mind taking a quick picture, guys? Come up for a quick picture. Malik and Scott.